2 minutes after 2, so why don't we get started? I know we'll have a good number of people who will be joining in the next 5 minutes or so, as is usual. We'll also recording this for later distribution, so we'll have a nice engaged audience, both live and streaming at some point in the future. I want to thank Dr. Daniel Lovell for his coming to us today to present this really great presentation on common JM labs and what they mean. I first saw Dr. Lovell at our town hall, our family days, if you will, at Cincinnati Children's Hospital a few months ago at our family days there, and I was so impressed with his presentation that I thought we just had to have him for a larger Cure JM group. So welcome, and Dr. Lovell, and happy to have you with us. Dr. Lovell is the Joseph E. Levinson Endowed Chair in Pediatric Rheumatology and the Division of Rheumatology at Cincinnati Children's Hospital Medical Center. And there he treats children with juvenile myositis, JIA, and a number of other inflammatory myopathies. His career and research have been focused on the evaluation and care of children with rheumatic and related diseases, including juvenile dermatomyositis. He was a member of the group that developed and validated a core set of outcome measures. These are very important in the evaluation of the progress children are making, as I think you all know, and a definition of improvement for children with myositis. It's my pleasure and honor to introduce to all of you Dr. Daniel Lovell. Thanks for being with us.
Thank you. It's my pleasure for being here. I'll share my screen here and see if can you see the slides?
Sure can. Yep.
Okay, I'll put them in presenter view here in a minute.
Yeah, great.
Yeah. Is that full screen?
That looks like full screen. Yes, it does.
Okay, very good. Well, it's my pleasure to be here. And we'll talk about labs and other tools to evaluate children with dermatomyositis and other forms of myositis, and give you some background on how we use them and how you can use them. Oftentimes when I give a similar talk to physicians and residents, they have a lot of other things on their mind. So I feel somewhat like this gymnast and the judges, where people are not really paying attention, but I don't ever see that the case when I talk to parents, because every parent has one of these children, one of these types of kids, in which motivates them to be at this talk. So we'll go ahead and get started. The objectives is to give an overview of testing, and then look at muscle changes in the muscle biopsy and help you understand what they mean. Look at lab tests. We'll talk about the Cmass, which is a assessment tool that you can do at home and is commonly used around the world to assess children with myositis. We'll talk about MRI, nail fold capillaries, and then most importantly, at the end, we'll talk about how you pull all this data together to inform treatment. So I just want to emphasize that a very important part of evaluating children with myositis is the history and the physical exam. In fact, they're central to the assessment of children, both at the beginning of the disease, but at subsequent visits when you're making treatment decisions. In addition to the history and physical exam, we look at various muscle enzymes, and then early in the disease, we do thyroid function tests, because if you have abnormalities in your thyroid function, it can affect your muscles and can be kind of a masquerade for myositis. And then because you have skeletal muscles in the esophagus, it's oftentimes important to do a barium swallow of both thick and thin materials to see, excuse me, if the esophagus is working normally. This is especially the case in children who have a very significant muscle weakness in their arms and legs and trunk, or if there's a history of coughing with eating or drinking. And then pulmonary function tests are important because a small percentage of kids with dermatomyositis actually get involvement of the lung, but it's also important because the muscles between your ribs that help you take deep breaths are skeletal muscles. And so if you have weakness of those muscles, it can be hard to get adequate ventilation, and the strength of those muscles can be tested with simple pulmonary function tests. And then we do an MRI of the muscle as part of the diagnostic workup, and in some instances, muscle biopsies performed, and we'll talk about each of those assessments. So first we'll talk about muscle anatomy, and the muscle fibers are unique in the body because they have the ability to slide over themselves. So when you straighten your arm, essentially what happens in the muscles in your biceps and your arm is that the muscle fibers slide over each other so your muscle can extend itself. And then when it contracts, the muscle contracts, then those muscle fibers slide back over themselves to get closer. And this is a very unique function of the muscles, and they're organized as shown in this slide here. Can you see my pointer okay? Yes? Can you see what I'm pointing to in the muscle? Okay, well, I'll try. So
yeah, we can. I think we can kind of see that, Dr. Lovell.
Okay, so
yes.
You can see here
yes.
These are individual muscle fibers. This is just a diagram. So these are individual muscle fibers that slide over each other, and then the muscle fibers are kind of held together by connective tissue, and this group of muscle fibers is called a fascicle. Now I point this, and then numerous fascicles exist in the muscles such as the biceps or quadriceps, other muscles in your body. And then those fascicles are surrounded by the outer lining of the muscle. So here's an individual muscle fiber, and then here's the muscle fibers together in a fascicle. So shown here is an actual muscle biopsy from a normal muscle. And what you see here is this is that binding that goes around the muscle fibers to form it into a fascicle. And then in here are the individual muscle fibers. And you can see these muscle fibers are all about the same size and pretty similar to each other. And then out here in this part of the muscle fiber are blood vessels and the connective tissue. So these are all blood vessels, and the blood supply to these muscle fibers come primarily from these blood vessels out here. So the next slide will show muscle biopsy from a child with dermatomyositis. And you can see up here are the muscle fibers, and they're all pretty uniform in shape and similar to each other. But what you can see at the edge of the fascicles, the muscle fibers start to be different. And so these muscle fibers here are smaller in shape, and there's inflammatory cells around them, far more cells around the muscle fibers here than in this part of the muscle. And this is typical of what we see in dermatomyositis, where the involvement of the muscle fibers is more at the edge of the fascicle rather than the center part of the fascicle. And you can see here's the connective tissue between fascicles. Here's a blood vessel, and you can see there's all this inflammation in this tissue here. Well, it's this inflammation at the edge of the fascicle that makes these fibers be more affected than the muscle fibers in the middle. Okay, and so Here's the muscle fiber involvement we'll talk about and look for. This is inflammation in the connective tissue of the fiber. And then here, number 3, is actual involvement of a blood vessel. So normally blood vessels are more like this, where it's just a thin membrane with not many cells around it, but you can see this blood vessel has a very thick membrane with lots of inflammation around it. And the opening in this blood vessel is actually compromised so that the flow of blood through this blood vessel is decreased, and that's why the tissue around here is involved. So these are the 3 things that we try to assess when we look at patients with dermatomyositis: the muscle fiber damage, shown in number 1, the amount of inflammation in the tissue, and then the status of the blood vessel. So the muscle biopsy itself is usually done before initiating treatment for kids with myositis, and one part is to help us make sure we have the correct diagnosis. Dermatomyositis and polymyositis have very specific appearances on biopsy, so it helps with making the correct diagnosis. It also, in centers in whom they're used to looking at muscle biopsies in children with myositis, you can use the biopsy to assess the severity of the muscle damage, because some of these muscle fibers get so damaged that they won't recover even with treatment, whereas many of the muscle fibers can recover. So you can assess the existent damage in the muscle, and also in certain findings can tell us that a child's at increased risk for certain complications or types of outcomes, either good outcomes or more limited outcomes. And then sometimes during the course of treatment of children with myositis, we'll do another biopsy because there's other factors that can develop during the course of treatment to cause muscle weakness independent of the dermatomyositis, such as steroid myopathy. And also, if you have concerns about the effectiveness of your treatment, or later in the treatment, if the child's doing very well and you want to know if it's appropriate to decrease treatment or stop treatment, sometimes we do muscle biopsies later in the course of the disease. So here's the lab tests. And so I've kind of grouped the tests in the components that we talked about in the muscle biopsy. So muscle fiber damage is measured or assessed by these tests here. These are all enzymes that are inside the muscle fiber. And when muscle fibers get damaged, they leak out these enzymes in increased amounts, so you can detect them in the blood, measure the level, and say the blood levels increase. So these 2 tests here are quite specific for muscle tissue. These tests here are included in the muscle, but they also come from the liver. And then the LDH is another enzyme in the muscle. So you can see that if you take all these tests together, about 90 to 98% of the time in children with dermatomyositis, one of these enzymes will be elevated. But you can see that none of them is 100%. So generally what we do at the onset of the disease before treatment is to assess all these enzymes and see which ones are increased in your particular child. So the ones that are increased early on before treatment or soon after treatment starts are the ones that are informative for your child. If, for example, the LDH is normal at the very beginning of the disease, then it's unlikely to be an informative enzyme during the course of the disease. So you figure out which one of these are relevant, and then you repeat them at frequent intervals to assess whether the inflammation in the muscle fibers, and the damage to the membrane is improving or not. And then these are measures of inflammation. The Neopterin is fairly specific for inflammation in muscle tissue. The erythrocyte sedimentation rate, or ESR, and C-reactive proteins are measures of inflammation, but they're very nonspecific, so that either these tests can be elevated if you have an infection, for example, because infections cause inflammation. These tests will go up, so they're not necessarily specific for muscle inflammation. But if they are elevated at the beginning of the disease, then they're simple and easy tests to follow to see if they're getting better as the child gets better. And then this test here, von Willebrand factor, is a enzyme that's inside the blood vessels, inside the wall of the blood vessel, actually. And if it's elevated, it suggests there's damage to the wall of the blood vessel. So with this kind of group of tests, we can assess all three components of what's going on in the muscle tissue itself. So these are indirect measures. And then there's also myositis associated and myositis specific autoantibodies. These are autoantibodies are normal antibodies, except that they're directed against your own proteins or tissues, which is not the normal thing to do. Myositis-associated autoantibodies are autoantibodies that are seen in some patients with myositis, but they're also seen in other rheumatic diseases. For example, anti-nuclear antibody can be seen in some patients with dermatomyositis, but it's also seen in a wide variety of rheumatic diseases. So it's associated, but not specific. And then myositis-specific autoantibodies are only seen in individuals with myositis. So they're helpful in terms of making diagnosis, but they also have specific associations, so that some specific autoantibodies are associated with only particular types of myositis. Overall, about 40 to 50% of children with dermatomyositis have myositis-specific antibodies. Some of them are associated with particular types of rashes that JDM patients get. Are associated with it. Some of them are associated with an increased risk for lung involvement, or calcium deposits in the skin, ulcerations in the GI tract, and then some are associated with better outcomes and some are associated with worse outcomes. So the big distinction between myositis-specific antibodies in children and adults is some of the same myositis-specific autoantibodies seen in children are seen in adults, and some of those are associated with the increased risk for developing cancer in adults, but it's not the case for children. And the associations of these myositis-specific autoantibodies are mild to moderate in strength. They're not absolute tests. For example, a fairly specific, high association test would be a pregnancy test. So if you get a pregnancy test 99% of the time or greater, you're pregnant. Whereas these myositis-specific antibodies, some of the patients have these tests be positive and don't have the particular association, and some patients do have the particular association. So they're not absolute tests, but they're kind of suggestive indicators. So they are done and should be done in your patient at the onset of the disease, and they get sent off to a reference lab. And then you can see whether the results are informative for your child. We'll not go into them in detail because there's a number of them, and the associations are kind of vary from one MSA to the next. So then we'll talk about the Childhood Myositis Assessment Scale. So this is a a test that we do with your child to measure strength of the muscles and also muscle endurance. So it can be used in children who are 2 years of age up to adults. And the test itself is focused on trunk and near trunk muscles such as the upper leg or the upper arm, because those are the muscles that are mostly affected in myositis, so that children can have weakness in their grip with myositis, but it's far more common to have weakness of the upper arm, so that holding your arm up to comb your hair is more generally an issue than the actual grip strength. And there are training videos and written instructions available. This test has been validated and is used worldwide for assessment of children with myositis. There's 14 items in it, and one of the items is, can you elevate your leg, single leg, straight leg raise? And some kids are so weak that they really can't get their leg off the table, so they get a score of 0. If you can raise your leg to get off the exam table, but not high enough to touch an object, like 6 inches, 6 inches off the table, then you get a score of 1. And then if you're able to raise your leg up to where you can touch the examiner's hand, you get a score 2. And then if you're stronger, then what we do is ask you to hold up your single leg, straight leg raise for duration of seconds. So the highest score is if you can elevate your leg for 120 seconds or more. And then if you can only do like 1 to 9 seconds, then you get a score of 1. So you can see a bigger score indicates more strength and endurance. So we've set this up in such a way that even children who are profoundly weak to children who have normal strength can be evaluated on the scale. So the range of score on the Cmass is 0 to 52, with the higher score meaning you've got better strength and endurance, and it takes about 5 to 15 minutes to complete, depending on how strong the kid is. The stronger kids take longer because they do more of the time test. Then there's a standardized scoring form, and you kind of go in the order of the items on the sheet. Kids will want to do the hardest test first or last, but to standardize it from one child to the next, one visit to the next, you go in the same order. It's the importance here on the Cmass is not that your child get a normal score, but rather, is their score the same or worse or better than their last visit, because it's used to assess change in the child from one time point to the next, one clinic visit to the next. It's hard to get a score of 52, but that's by intent, because once a child gets a perfect score, then it's hard to show improvement after that. There's a little trick, is that once they get near to 52, then you ask them to hold up both their legs at the same time in a straight leg raise, and that's even harder than the single leg. And then you score it the same way, like up to 120 seconds. That's really hard to do, but it's not, again, not so important that your child get a perfect score. It's important as to whether their score today is better or worse or the same as last time. So that's how we use the Cmass. The Cmass was developed for use by patients and parents, healthcare professionals, and there's a home test application where you can do this test at home. It's very nice application. For each test, the video will show you how to do the test, how to score the test, and you just go from one item to the next, and you get the total Cmass score, and the application keeps track of the score, and then at the end we'll give you a summary score, and then it saves those score in an individualized report, and you can use that report to save it for your own use or send results via the internet to your provider, for example, so you can do home scoring that way. And here's the link to the application, and I'll put it in the last slide here. But it's a very nice application for use by parents to evaluate their own child on the Cmass. So here's the MRI. And again, the MRI is used in the initial evaluation of the child to identify the extent of muscle inflammation and which muscles are inflamed and how much damage there is. Also, you can use the MRI to guide the area in which you should do the muscle biopsy. And I'll show you how that works in a minute. And then you can also do MRIs during the course of the disease to help identify disease activity. And then once you get to success, where the child has normal strength and normal labs, and you're wondering whether you can taper or stop the treatment, then the MRI can be helpful in that regard. So here's a picture of an MRI of the upper leg muscle in the child. So this one on the left is a cross section of the muscle. So here's the skin, and then here's the subcutaneous fat, and then here's the muscle tissue, and then here's the bone, the femur. So what you can see here is that the muscle tissue in the quadriceps has different appearance, and actually this darker muscle is the normal muscle. The inflamed muscle with increased water in it shows up whiter here. So you can see that, as is the case with almost every child with dermatomyositis, there's portions of the muscle that are more involved than other parts. So if you were to want to do a muscle biopsy of a child to assess the disease further, then you want to do it from this muscle, for example, as opposed to this muscle, which looks pretty much close to normal or more normal. So it helps guide where you do your muscle biopsy. And then this is a picture of the muscles longitudinal. So here's shown here, the bones in at the ends of the leg bone, the hip joint on each side, and then here's muscle tissue. And you can see again that the muscle that takes up, that looks lighter, is abnormal. And so you can see in this child, most of the muscle is abnormal, but even in the same muscle, there's parts that look more normal, and then parts of the muscles that look more normal. So it's fairly diffuse or widespread involvement, but it's patchy. So but this is a characteristic look for inflamed muscle. Okay, now the nail fold capillary is something that you can do with children that's completely painless and non-invasive, and even little kids can enjoy doing this. So what you look at is the blood vessels at the tip or at the fingers around the capillary, and this is a way to easily look at blood vessel involvement that's really part of dermatomyositis. Part of dermatomyositis is a muscle inflammation, but an equally, and perhaps in some patients more important part, is the involvement of the blood vessels. And these blood vessels get involved pretty much through major parts of the person, such as the skin, the muscle, the GI tract. So you can use capillary changes to be kind of a mirror to what's going on in other tissues. And the findings in the capillaries get better with response to treatment, but not as quick as lab tests do. Here's the various ways you can do the assessment. This is what's called a capilloscope, and it's a little magnifying glass with a light in it, and it costs a couple $100. And this is an ophthalmoscope that you use to examine the ears, and you can adapt that to, look, here's a dedicated microscope that shows you findings in the computer screen. And then here's one that's been validated or developed specifically for nail fold capillaries, and it's in the neighborhood of about $10,000 to get the little scope used to look on the blood vessels, and also the computer program that shows the findings. So here's what you can see. Here's where you look. It's right at the capillary is right at the base of the cuticle. And you can see the characteristic changes in the cuticle you see in kids with dermatomyositis. You can see the cuticle here is a little bit kind of rough looking. And then if you look at the skin here, just apparent to your normal eye, you can see these little red dots at the cuticle. And these are dilated capillaries. So here's what it looked like normal. It's a uniform little network of little capillaries that come up, circle around, and go back. So this is normal appearing. What you see in dermatomyositis is these enlarged capillaries. And that's what you're seeing, these little red dots is just the evidence of these very enlarged capillaries. And then there's sections here in the tissue by the cuticle in which there's no vessels, so there's vessel dropout, and then it's compensated by these very large capillaries. Here's another example of large tortuous capillaries, and then a section of the cuticle that doesn't have any blood vessels at all. So this is the same sort of thing that can happen in other parts of the skin, in the GI tract, and it's these areas where they have poor circulation that are prone to break down, so you get ulcers in the skin or ulcers in the GI tract. And it's the same thing that happens in the muscle, so that there's areas where the blood vessels are absent, and then the muscle fibers around that blood vessel also are compromised because of poor circulation. So now there's the important part of the discussion about the first part is treatment goals. So normally with the treatment of dermatomyositis, you use systemic suppression of the immune system, because it's the immune system that's attacking your own child's tissue, and it needs to be suppressed so your child's muscle can heal itself. Steroids are commonly used because they work very quickly and they're effective, but they have lots of side effects. So you use another immunosuppressant medication to allow you to taper the steroids as quickly as you can. How quickly you can taper varies from child to child. And the other treatment goal is to avoid allowing the disease control to escape, so that the disease flares up again or gets worse, because disease flares after you get the disease under control are oftentimes more difficult to treat than the first manifestation of the disease. So you use a variety of different information to come to a decision. So you have to take all these different pieces, fit them together to get a decision or a view of how the child's doing at that particular visit. And I think it's best done as a shared decision, because your physician has 10, 15, 20, 30 minutes to evaluate your child, whereas you have 24 hours, 7 days a week in between the visits to see how your child's doing. So you have observation of how the child's functioning in the home, in the school, with other kids, that your doctor can only get as indirect information. So you have a lot of information about how your child's functioning and feeling that the doctor can't make as detailed an observation. The doctor's evaluation is limited to that visit and lab tests and that sort of thing. And it's important you take all the available information, the information about how the child's doing at home, keeping up with siblings and peers, how they're feeling, how their appetite is, as well as stuff that you can do in the clinic, such as lab tests and the Cmass. So you take all that information together, because no single piece of information is a perfect indicator of what you should do. And at each clinic visit, you have to make a game time decision about whether the child is better than the last visit, the same as the last visit, or worse, because that determination will tell you what you do with the treatment. So you all work together to gather all this information, make this game time decision, and then that will inform what you do with the treatment, whether you increase, decrease, or keep the treatment the same. And my approach is to do frequent visits so that you can taper steroids or other medications in small steps, so that you minimize the chance of flare, but you keep steadily decreasing the steroids if you can, if it's appropriate. And we found that remote visits like telehealth visits work quite well for myositis treatment, because you can do the muscle enzyme tests in a local lab, and the Cmass can be done by the family either before the visit, or the physician can do it with the child during the remote visit, because all the Cmass tests are things you just ask the child to do and you watch whether they can or can't. So the Cmass can be done just as effectively remotely as it can in the clinic. And you, the parent, are still there to make the observations about how the child's activity is and their appetite and that sort of thing. So remote visits work very well for following children with myositis. So the key pieces, you have to use the history to see how the child's doing in daily activity, whether they have muscle or joint pain, and then what their overall energy is. The physical exam, you can look for muscle tenderness, see if the rash is better or worse, and you do the Cmass. Then you do these lab tests we talked about. And then if all the above are normal or improved since the last visit, then you say the child's better, and you can taper the steroid by 10 to 20%. If they're worse, so if any of these components are worse, then you need to increase the steroids back to the dose they were at least on the prior visit, and sometimes higher, so that you hopefully decrease the chance of having a major flare. And if all these things are the same as the last clinic visit, then you're going to keep the steroid the same and see how they're doing the next visit. So that's how you put all this information together to inform your treatment decisions for the child. This is one of my favorite quotes. He is not only dull himself, but he's the cause of dullness in others. So I hope I haven't done that for you today. And I thank you for your attention. I'm very happy to answer questions. And then here's the link to the Cmass application where you can do it at home. And if you can't copy this down, all you do is Google Cmass home use, and it'll get you to this application. Okay, so any questions?
Shannon, I think we had a couple in the chat.
Yeah, I think we did, Dr. Lovell. So one question that is on the mind of a lot of us parents is, what tests would you recommend for lung involvement?
If the child's old enough that they can participate in pulmonary function testing, that's a sensitive indicator of improvement from visit to visit. The test that's most helpful to determine whether a child does have lung involvement is a CT scan of the lungs. So it's called a high resolution CT scan. So that's a specific type of CT that's done the lung to look for the involvement. So that's used to make the diagnosis. Then you can use pulmonary function tests in between visits to assess whether the child's improving or not. You don't like to do the CT test kind of on a routine basis because of the radiation exposure, but it's helpful to make the diagnosis. And then if you have lung involvement and you have some question about its severity or its cause, then in some instances you end up doing a lung biopsy.
Mm-hmm.
But on a day-to-day basis, you can do the pulmonary function tests, and you can also on the finger measure the amount of oxygen in the blood. Very simple test. And in some instances, if the children's lung function is such that their oxygen saturation in their blood is down, then you can measure it with the little thing they put on your child's finger on a routine basis. And then the other test for lung function is kind of non-specific things such as endurance, ability to keep up with peers, that sort of thing. So those are the things.
One thing that comes up quite often, Dr. Lovell, and you've got so much experience, I think all of our families would be interested to hear any thoughts you might have on do you recommend, or what signals would a parent look for any additional cardiac testing? You know, depending on where you're located in the US or abroad, some hospitals do cardiac testing at diagnosis. Some hospitals do, you know, every 3 to 5 years with active disease. Some hospitals don't do any cardiac testing unless there's a reason to. Do you have any thoughts you might share with some of our new parents?
Well, I think echocardiography is routinely available throughout much of the world, and it's able to look at cardiac function, how effectively the muscle contracts. And so echocardiograms are a good way to assess the presence of cardiac involvement, and also to follow the child to see if the cardiac function's improving. And it's completely non-invasive. It's just like the ultrasound you do for pregnant women. So it's a very non-invasive test, so it can be done repeatedly without danger to the child. So echocardiogram is I think the way it's generally followed. If you have more questions, and there's specific imaging you can do for the heart, but the echocardiogram is kind of the starting point and the recurrent testing method.
Excellent. Well, we have some more questions that have come in by text and message, but I don't know if anybody wants to jump off of mute and chime in with any questions that might be on your mind. We'll give everyone a minute.
Yeah, hey Shannon, this is Bobby. You know, with Peyton, for the most part, most of her labs have been within range this last year. The LDH seems to be the most stubborn. I mean, has anyone else found that to be true, that seems to be one of the most, you know, stubborn labs to normalize, or is there anything more that you can add, Dr. Lovell, to that?
Well, all these enzymes have been tested longitudinally in children to see how sensitive they are to change and that sort of thing. And LDH is the one that is most likely to go up with flares of the disease. So it is a more sensitive one, in many children, more sensitive than the other enzymes. So it can be one of the last ones to get better. But Bobby, it's important to note that LDH like the SGOT and the SGPT, there's other things besides muscle tissue that can cause LDH go up. So it sometimes LDH is an indicator of bone mineralization or bone turnover also. So your treating physician needs to keep an open mind as to perhaps something in addition to muscle inflammation is causing the LDH to go up, so that steroid effect on the bone, for example, can cause LDH to go up. So in SGOT and SGPT are also found in the liver, so that they can go up if, for example, some of the medications are causing liver side effects. Then the SGOT, SGPT can go up based on the medication effect on the liver, not just strictly on the skeletal muscle. So SGOT, SGPT are also called AST, ALT, and also LDH have other function in the body, so you need to keep an open mind. But certainly LDH is one of the more sensitive ones in some children to muscle inflammation, so it might be the last one to get better.
So she's having like her first MRI tomorrow. So I guess that would, like, let's say, when we get those results, that could maybe indicate what else might be driving that to be elevated, right?
Right. So if for example, one of the muscle enzymes is elevated, but the MRI, the muscle looks perfectly normal, then it would cause you at least question whether there might be another cause for the LDH to go up.
Okay. Yeah. Thank you.
And with the with SGOT, SGPT, and LDH, you can do tests that look to see what part of the LDH comes from the muscle, what part of the LDH comes from the bone, that sort of thing. So they can do kind of testing for LDH if it's high enough to see where it's coming from. And the same thing for SGOT and SGPT. You can see whether it's coming from the muscle or whether it's coming from the liver, that sort of thing. So that's special testing that you do for breaking down the sources of those particular tests.
Okay, that was
Same thing for CPK. CPK can come from cardiac muscle or skeletal muscle. It can even come from the brain. So you can do breakdown of CPK results into its components to see where it's coming from. Okay.
Okay. Yeah. Thank you again.
Yep.
Dr. Lovell, a practical question, as you've had many decades in pediatrics, children sometimes have a mind of their own.
They always do. They always do.
Is it, some doctors recommend that your child enjoy a couple days of rest before having your labs drawn, and some children appear to be able to do their labs right after engaging in heavy playground play or other kinds of sports. Do you have any thoughts on whether or not rest is sort of required, or is that something you've run across in your practice?
Well, I've run across that. I have, high school athletes that can make their CPK go to 2,000 to 3,000
Wow.
just from a football game. In fact,
Yeah.
if you take people who complete a marathon, every one of the people that complete a marathon, their CPK is going to be in the neighborhood of 3,000 to 5,000 or more, just based on the damage caused to the muscle fiber from abusing your muscles when you run 26 miles, right? So every person that runs a marathon, they're causing enough muscle damage to elevate the enzyme. For example, CPK is so sensitive that if a child gets an IM injection, like immunization, that can make the CP go up to a couple hundred just because of the damage to the muscle tissue with the needle. So CPK is a very sensitive test. If if you get results that are clearly different than what you've gotten before, and the child's done something unusual, then you would probably be wise to have them rest and reassess it afterwards. I generally don't routinely ask kids to rest for 2 days because it's not going to work, right? I mean, they're not going to do it. So you just have them do their normal level of activity, and that will be part of the background. But what you're looking for is changes if they're elevated, if they have the same level of activity, all the time, and then there's a change, then it's more likely related to the muscle disease itself if their activity is pretty stable. And little kids, when they go out and play on the playground and do normal stuff, they very seldom elevate their muscle enzymes. It's only when their play gets structured and it's under the direction of an adult that makes them do bizarre stuff like wind sprints or tons of push-ups or all sorts of stuff that coaches make kids do. That's when they can elevate the enzymes, or when kids start lifting weights, that sort of thing. Okay, so but for little kids, when they're just playing normally on the playground and with their friends and that sort of thing, it very seldom causes any problem. And since it's stable from one visit to the next, it's easier to say any fluctuation, worse or better, is likely due to changes in the underlying muscle disease. Okay. And when kids get older and they get into structured sports, then it becomes more of an impact. And so you may want to have kids not play a whole weekend of a soccer tournament and then get their labs done on Monday, because they'll probably be elevated from that to some extent.
That makes sense. And then one last question. So if the only lab that is elevated is the von Willebrand factor, does that tell you anything, Dr. Lovell? Anything such as potential vascular damage or anything else that you would glean from that?
Right. Well, it's an important test. Yeah, because the vascular component, unlike the skeletal muscle component, the vascular component is not so much related to inflammation. It's related to other aspects of the disease that affect the internal cells that line the blood vessel. So the steroids and other immune suppressants we use work extremely well, or more focused on the inflammation in the skeletal muscle. And if those are normal and your von Willebrand factor is abnormal, and you see nail fold capillary changes, for example, you can say, okay, the vascular component of the disease isn't as responsive in this patient, or is more likely to be active than the muscle inflammation. So they don't necessarily track together, because they're caused by different abnormalities. Okay, so von Willebrand, nail fold capillary are tests to assess that vascular component, and it doesn't necessarily track the same way as inflammation of the muscle. So it can be important, because it's the vascular damage or the vascular component that causes skin ulcers or ulcers in the lining of the GI tract. And so those can be very severe complications of the disease that can occur even if the muscle inflammation is suppressed, so you need to kind of keep track of both.
Well, Dr. Lovell, you have done such an incredible job of giving us all such a nice overview. I know we have a couple more questions that are a little bit more general. So Tiffany, I'm going to send you an email, and maybe we can connect. We have some family support representatives in your area, and you and I can connect one-on-one when you don't have a sleeping baby, and have a chance to be able to talk a little bit more. So I think, Lauren, that was all the questions that we have right now. So back to you.
Excellent. Thank you. Thank you, Dr. Lovell.
Thank you.
Welcome.
And I think we're going to wrap up here in a second. For those that can stay on, we'll have a more informal session. I think it's a small group, so I don't think we'll do breakout rooms, but it's often our nice casual time just to be able to talk with one another. And Shannon, if you want to, before we move to that, give us any closure around where we're at on our Giving Tuesday Holiday Challenge.
Yeah, sure, absolutely. So I think everyone, Dr. Lovell, let us thank you again for your
Welcome.
time. We'll let you probably get back to a very busy day, but as we have, you can see in the chat, Dr. Lovell, everyone is very, very appreciative and very thankful of your time and all of that great
Happy to do it anytime. Thank you.
Thank you so much.
So long.
So as Lauren alluded to, as most of you know, we are in the middle of, we have two big fundraisers a year at CureJM that pays for all of the research that Dr. Lovell was talking about in the family education and the doctor education. So we're in the middle of one of our great campaigns, our end of year campaign. So if anybody has any questions or wants to join, reach out to Lauren or reach out to myself, Shannon.Malloy, Malloy at curejm.org. Or you can find us on any of the social channels, or Lauren will probably email this recording out. Is that right, Lauren?
Yes, I will.
Yes. So just reply to Lauren if you want to join. We'd love to have anyone be a part of making all of this work possible. As you know, with a rare disease, oftentimes it really is up to families to fund this kind of family education and physician education. So we appreciate everyone being on the CureJM team. And I think, Lauren, since we really just have parents and grandparents, I guess we only need 2 breakout rooms. I don't know. Did you set those up, or would you like me to?
I with the smaller group, I didn't set them up thinking we might all stick together, but I can do that.
Unless Terry and Randy are it might just be parents. Or we could all stay together. It's possible. It's Tiffany, I know, was on mute earlier. Tiffany, are you able to talk now? Is your baby? We don't want to wake a baby. Never wake a sleeping baby. So, Tiffany, I did send you an email, and I don't know if you can see us, but be happy to connect. I know Bobby would be happy to connect, Debbie as well later, to share our experiences as parents. We also have a trained family support network that will be reaching out to you. So all of those questions, excellent questions, Tiffany, and we can definitely get you answers on all of those. Bobby and I specifically